Okay, so this is chapter 5, um, pain. Today we're reviewing pain and comfort, a core nursing concept in Med Surg. First, the definition of pain is always what the patient says it is. Our primary role as nurses is to advocate for patients by believing their reports and acting promptly, while respecting their values and reference preferences. Categories of pain. We have acute pain, which has a sudden onset, lasts less than 3 months, and initially serves a purpose as a warning sign. Common causes include trauma, burns, lacerations, or fractures. If left untreated, it can increase morbidity, mortality, and hospital stay. Chronic pain lasts longer than 3 months, often has a gradual onset, and serves no useful purpose. It can impair relationships, mobility, and cause emotional and financial burdens. Examples include rheumatoid arthritis, chronic back pain, and diabetic neuropathy. Chronic cancer pain is often undertreated, affecting multiple sites, but focus is on the primary area. Then we have types of pain. We have nociceptive pain, is normal pain processing. It's involving nociceptors and chemicals like prostaglandins, histamine, and substance P. NSAIDs block prostaglandin production. Endorphins and norepinephrine help reduce transmission. Neuropathic pain. Another type of pain is neuropathic pain, which comes from nerve damage and is described as sharp, burning, pins and needles, or phantom limb pain. Some responses to pain, such as physiological, which is increased pulse, respiration, blood pressure, and dilated pupils. We have behavioral responses, grimacing, moaning, guarding, restlessness, impaired mobility. And psychological responses include fear, anxiety, irritability, anger, depression, fatigue, and low self-esteem. The assessment for pain is subjective. So self-report is the gold standard. Use scales like the numeric rating scale or the Wong-Baker FACES for children, older adults, or patients with language barriers. For chronic pain, assess ADLs and functional impact. For nonverbal patients, observe behaviors, involve family, and consider tools like PACSLAC, PACSLAC 2, or PAINAD. So PACSLAC 2, PACSLAC 2, or PAINAD, PAINAD. And management for pain. The first step is acknowledging the patient's pain and responding quickly with relief measures. Discuss realistic expectations. Pain may not be eradicated, but reduced to an acceptable level. Non-pharmacological options include rehab, PT and OT, physical therapy, occupational therapy, heat or cold therapy, exercise, massage, acupuncture, mindfulness, relaxation, music, or guided imagery. Some pharmacological management follows a multimodal approach, combining classes of drugs. So we have three. The first one we have is non-opioids, such as acetaminophen, and the max is going to be 4 grams or 4,000 milligrams a day. Lower for the older adults, like 3,600 milligrams. NSAIDs like aspirin, ibuprofen, naproxen, uh, watch for GI irritation and renal effects. We have opioids. The second pharmacological management is opioids, which includes morphine, fentanyl, hydromorphone, oxycodone, um, and dual-action drugs like tramadol avoid uh, meperidine and codeine. So those aren't used as much now. Key principles, titrate, and you want to titrate to the smallest effective dose. Watch for side effects like constipation, nausea, sedation, and respiratory depression. And the reversal, the antidote, is naloxone or Narcan. And the third pharmacological management for pain is adjuvants. And they're anticonvulsants, gabapentin, antidepressants, lidocaine patches, used especially for neuropathic pain. And patient-controlled analgesia, PCA. So patients must be alert and able to use it themselves. Safety is a top priority. Only the patient presses the button with lockout intervals to prevent overdose. Nurses monitor sedation, scores, and respirations frequently. Heat and cold therapy. Heat increases circulation, relaxes muscles, and eases stiffness. Avoid You want to avoid using it over bony prominences, implants, or pregnancy. Some cold for cold therapy. Cold reduces inflammation, bleeding, and swelling, and numb sensation. You want to avoid it in patients with vascular insufficiency or Raynaud's. Some special considerations for older adults. Pain is often underreported. Many believe pain is part of aging, fear addiction, or don't want to bother others. So start low and go slow with medications. Older adults are more sensitive to side effects and drug interactions. In summary, pain is subjective and must be respected. Nurses advocate by assessing thoroughly, combining non-drug and drug therapies, teaching patients about safe use, and adjusting care for vulnerable populations.